Okay, perfect. So here we are finishing up block 3. We did the first 20 questions from 100 to 120 in the last video. Got some feedback. Try to follow some of that. So people wanted me to go a little more in depth. Apparently I was much more in depth in my previous NBME videos. Maybe I feel a little burnt out, so I'm going to try to go a little more in depth the best I can. As usual, keep in mind if you're going to ask any questions about any of these problems that I try solving here, reference to the number down here rather than, this would not be question 11. This would be question 121, and the next one would not be 45, it's 122, and so on. Makes it a little easier, and if you could put the timestamp, that's even better, so that I can respond to any questions you might have about anything I'm talking about here. Other than that, there's the whole factor of like, what is this page number here? So these page numbers here are in reference to my own annotations, my own annotated first aid. So that's a whole different thing. Alright, so this question, number 121, 3-year-old boy is brought to the emergency department because of a nosebleed that cannot be stopped. Very common thing. Platelet count and thrombin time are within the reference range. Partial thromboplastin and prothrombin times, so PTT and PT, stuff like that, are both prolonged. Which of the following coagulation processes is most likely to be affected? Right? So platelets are normal, so it's not a platelet disorder like Glanzmann or Bernard-Soulier. Thrombin time is normal, so fibrinogen is working just fine. Right? These are the things we're supposed to evaluate. PT and PTT are both prolonged, which is what they mentioned in the question. So that means that the common pathway must be involved, right? Because both things are getting prolonged. Only factor 10 of all the answer choices they listed, only factor 10 is part of the common pathway. So that would be the only one that you could possibly pick as a viable answer choice for why this 3-year-old is presenting with a nosebleed and a prolonged PT and PTT. All right. So if we go back and look at our coagulation cascade, now I know they have factor 12 over here, activation of factor 12, but the other ones, right, so let's take a look at what's happening here. So this one says this is factor 12 here. This had nothing to do with our question, so it's completely irrelevant. Over here we have 8, which would basically be hemophilia, right, hemophilia A, and this is not a question about hemophilia. This one's 9, which would be hemophilia B. Right, so you can kind of cancel out both of these as choices because this is not a question about hemophilia A or B. And then this one, the Stewart factor, right? That's the 10 that we know is most evidently part of the coagulation cascade common pathway. So you do have to memorize the coagulation cascade for your test. The only real and best way to do it is to kind of just keep rewriting it and keep using it in your own head until you memorize it perfectly. So if you look at everything, right, you know that 12, 11, 9, 8, right, these are all part of your intrinsic pathway, right, and that's out here. And then this portion, the orange one, this is your extrinsic pathway with tissue factor, and that only really uses 7 and tissue factor. So those two guys have their own thing. You know from PIT and WEPT, right? WEPT is the mnemonic WEPT for warfarin extrinsic PT, right? So that would be factor 7. PIT, PITT, and then the whole HTTP is another mnemonic. HTTP is at the beginning of every web browser, every web link. So HTTP reminds you of heparin, and then the TTP is PTT, which is for your intrinsic pathway, right? So PIT, PITT, you can spell that like that too, and all of those little things help you remember where things are and what they're related to until you've mastered it and you don't need mnemonics like that anymore. The only factor that they mentioned in all their answer choices that was part of the combined pathway was factor 10, right? Any of these guys get affected or messed up, then you can expect a prolongation of both PTT and PT. So not a bad question, pretty typical of how these things will present. Hemophilia A and hemophilia B have their own things, right? Very significant diseases, very important diseases. You do have to know them extremely well. So let's take a look at where they talk about that real quick too. So that's part of the first few diseases they talk about with coagulation disorders, right? Coagulation disorders, hemophilia A, B, or C. C is a deficiency of factor 11, and that's autosomal recessive. And this is very unlikely to be tested. It's not really a very common question. A and B are both X-linked recessive, which makes it more common in men, right? Because men really only have one X chromosome. So if you have the recessive 1X with a hemophilia A issue, you don't have another X chromosome to make up for it. So men are the ones that are usually going to be the one with the hemophilia in your questions on step 1 and UWorld. Women are usually going to be the one with von Willebrand disease, which can occur in both men or women. But they try to make the female questions about von Willebrand disease, which is just autosomal dominant, right? So here you can see that PT would not be affected, right? Because 8 and 9 are both part of your intrinsic pathway. So it's not really going to be there's no reason for you to pick 8 or 9, right? So let me just put that in here too. Choices C and D refer to hemophilias, and those only affect your PTT. Right, that's it. Very important to be able to differentiate what's going to be affected in each kind, right? I have this little snapshot right here that I discussed in my coagulation videos, in my hemonc videos. Very important to make sure you can master this stuff. Know this by heart. You should be able to talk about this without needing a book, right? This is part of mastering hemonc. So this little snippet right here is something you could take a screenshot of and just memorize, because this, when we did the hemonc videos, this was a big part of knowing how to identify what condition someone is presenting with. Alright, so next question, 122. 41-year-old man comes to the physician because of a 6-week history of numbness of his right hand. He works in construction. Sensation of pinprick is decreased in the thumb and over a portion of the anterior forearm, right? So anterior forearm and thumb. Physician suspects that there is compression of the C5 and C6 spinal nerves as they exit the spinal canal. Weakness of which of the following on the right is most likely to confirm the diagnosis, right? So now I will share this resource. This one I'll put it in the chat. Geeky Medics. This was actually a pretty nice resource for understanding some of this upper nerve anatomy. Anatomy, musculoskeletal anatomy in general, is all stuff you master through repetitive revisiting of all the musculoskeletal stuff, right? There's no easy way to do it. There's no easy way to do any of this, really. But the more times you look at it and the better the resources you look at, the better you start getting at it, right? Visual understanding of these things is probably one of the best ways to master it all. So our question is actually about Erb palsy. They mentioned C5, C6, right? Which right here you can see for the axillary nerve. But our question is actually going to go on, right? To Erb palsy, you have to remember Erb. Oh, let me show you. I forgot to show you that part right here. So Erb palsy, traction of or tear of upper trunk, right? You have to remember Erber trunk or upper trunk to remember C5, C6 affects your upper roots and causes Erb palsy. Erb palsy is also just known as waiter's tip, right? So this is kind of how you your waiter would ask for his tip, by making it look like it's not so suspicious. And things that get affected and what kind of deficit that leads to, it's all listed out here very nicely. Not so bad at all. Many ways it can occur, but you can see axillary nerve will be involved here, right? As well as the suprascapular and musculocutaneous nerves. Patients will also have sensory loss in those nerve areas, and then you have lateral shoulder and forearm problems, right? So now to memorize that, of course, you should memorize this, right? So this is literally ARM. It's your arm, right? And our patient, he has an effect on this forearm area, the upper forearm right here, and then the thumb, right? You can see kind of that distribution is coming around, right? The radial nerve, the musculocutaneous, all of that. A lot of it got affected when you affected this upper area right here, right? Number 1. This is where the damage is for our patient. So if you look at all your answer choices, abduction of the upper extremity, adduction of the index finger, elevation of the shoulder, extension of the index finger, or flexion of the wrist. Now, you should know what nerve is mainly involved or what muscle is mainly involved for each of these actions. It's very important to be able to do that. Very important to be able to do that. There's really no other way to answer such a question. If you don't know what nerves do these actions, you won't know how to answer this question. So now, the upper trunk has roots from C5 to C6 and provides axillary, suprascapular, musculocutaneous nerves. You lose abduction, lateral rotation, and flexion supination, respectively. Right? Musculocutaneous is all about flexion, so you're going to lose that, but not flexion of the wrist, right? Not the wrist. That's further down. This is proximal flexion up here, right? So that's going to be gone. Lateral rotation is another thing that will be gone, but it's not in one of your answer choices. And abduction. Abduction means like you're being abducted by aliens, so you raise your hands. Being able to raise your hands is not going to be something you'll be able to do if you have Erber palsy, and that's abduction of the upper extremity. Another way to remember that is this concept right here, right? Sorry, not this one, this guy right here. One of the ways the injury occurs is you can see from both of these images, that the injury is occurring for the same goddamn reason, right? Excessive stretching right here, right? Way too much stretching right here. And that excessive stretching, you can imagine, has messed up his shoulder and upper arm in such a way that he can no longer do this. He can't, because it's just completely ripped off, right? So that's something that I always used myself. Whereas when we go to Klumpke palsy, right, he's already stretching in that way, and now in this case scenario, you can see in both in adults, right, as well as in the infantile version, right, the problem is pretty much looking the same, and it's a different kind of stretching compared to Erb palsy. So I always remember this, because this is the way the guy is going to be holding the branch, right? This is also the way the patient is being grabbed, right? If it's an infantile question, so you have to make up, basic things like that to kind of memorize what happens, right? Adduction of index finger. First of all, you should have canceled out B and D to begin with, because fingers would not be the one that are affected from an upper, right, C5, C6 problem. It's not going to go to the fingers per se. That's not what's the main issue there, right? You can see musculocutaneous and median. The radial and ulnar nerves are the ones that really have effects on the finger, and that's going to be later on. C7 to T1, you can imagine more effect on fingers, and it even starts from right here, right? Because Klumpke is C8 to T1. That's everything else that wasn't mentioned here. We're skipping over C7. C7 is right here for wing scapula, and it's a bigger issue for the scapula than anything else. So you don't have to worry about that so much. But yeah, not a bad question. And you get many questions like this one too. It's all over UWorld. It's all over step 1. So know it pretty well. 37. A 4-month-old, this is 123. A 4-month-old boy is diagnosed with a rare autosomal recessive skeletal dysplasia involving abnormal endochondral bone formation. Genetic analysis shows null mutations in a gene for a protein that controls the traffic of vesicles into the Golgi complex. Electron microscopy of this patient's cells will most likely show which of the following findings. Right, so there's something wrong with the protein that controls the traffic of vesicles into the Golgi. You look at all your answer choices, what's the problem going to be with? Now this was a pretty interesting question, but there were some answer choices you could immediately knock out. You could definitely knock out E and F both, because lysosomes are not going to be the one that's affected, right? Here there's a problem with the protein that sends things from the rough endoplasmic reticulum to the Golgi, right? And that's going to be your COP2. So let's take a look at that. This is something that you need to master in such a way that you never need to revisit it again, right? 2 steps forward, 1 step back. You have your rough endoplasmic reticulum right here, pretty much attached to the nuclear envelope. And then you can see the legend or the key right here. So COP2 is for 2 steps forward, right? Basically, things go from the RER into the Golgi in that manner, and that's where our question's problem is. COP1 is back to square one, so it brings it back from the Golgi to the RER. Later on, Clathrin is the guy that has things to do with the endosome or lysosome, right? And our question is not about Clathrin, so we don't care about lysosomes. So that takes it down to a 25% chance of getting it correctly. Now, decreased RER or decreased SER, you could knock out answer choice B as well, because the smooth endoplasmic reticulum is not going to be related to this at all. Right? There's a huge difference between the RER and the SER. The smooth endoplasmic reticulum is just a site of steroid synthesis, right? It's all S's. Smooth steroid. Right? Steroid synthesis. As well as detoxification of a couple of drugs and poisons. And this is the one that's smooth, which means it has no ribosomes. This stuff, the SER, is completely irrelevant to anything we see on this page with the vesicular trafficking proteins. So now you're up to a 33% chance of guessing correctly. Are you going to have a decreased RER, a dilated RER, or increased SER again? Oh, you could knock out D also, right? Because we don't care about the SER. This question has nothing to do with the SER, as I said here, right? So choices A and B make no sense, nor is this a lysosomal storage disorder, so knock out E and F. This is also not a disease related to the SER, so you can knock out D as well, and that kind of just leaves you with C. There's really no reason for you to have a lower amount of RER. Why would you have fewer RER, right? And you're not going to have, where else is there? Well, we knocked out everything else, right? We knocked out any answer choice with SER, nothing to do with lysosomes. So in that manner, it just becomes a choice between A or C. Are you going to have fewer rough endoplasmic reticulum, or are you going to have a dilated rough endoplasmic reticulum? Now, if the problem is things from RER to the Golgi, right, can't go from the RER to the Golgi, then your RER is just going to get very dilated, right? Dilated rough endoplasmic reticulum. That's it. It's just becoming more and more full because it can't send its stuff to the Golgi. So this was a question literally just testing you on the memory of what COP2, COP1, and Clathrin do, and I mainly made this up when I was first making the video from Biochem talking about this section, but this is not a page you ever come back to. Also make sure you know the signal recognition particle stuff, and of course know eye cell disease, right? Where the main issue is that this is a lysosomal storage disorder with the defect in this, right? Pretty long name, NAG1-phosphotransferase, N-acetylglucosamine 1-phosphotransferase. Failure of the Golgi to phosphorylate mannose residues, right? They can mention any of these things in a question, and as soon as they mention that, you should know immediately they're talking about eye cell disease. All right. 124. An 80-year-old comes to the emergency department because of a 2-day history of feeling funny. So 80, first of all, she's really, really old, right? Above 65. She says, I have lost my pep. She has never been admitted to the hospital, but she has a history of poorly controlled hypertension. She just started her medication 2 weeks ago, but does not recall the name. Her blood pressure is a little high. Physical exam shows no abnormalities, excuse me. Her serum potassium is low, right? Between 4 to 5.5, generally speaking, is the reference range. 3 is too low. Which of the following drugs is the most likely cause of this patient's condition? So you're just thinking of any medication that's going to cause her to lose potassium, right? And you look at all your medications, you got clonidine, hydrochlorothiazide, lisinopril, metoprolol, and triamterene. First things first, you should know all of them. You should know what they all do, right? Let me just... Okay, so now here, when you look at all these medications, right, for her, lisinopril is an ACE inhibitor, metoprolol is a beta blocker, triamterene and clonidine are other medications you definitely want to make sure you know very well. We can find all of them, and I have information for all of them here. But hydrochlorothiazide is a thiazide diuretic, and thiazide diuretics are associated with hypokalemia, right? And then you have to remember what other ones are also associated with hypokalemia. Loop diuretics, right? Loops lose calcium also, and that would be given to you, but it wasn't, right? And that's another thing you have to memorize when you're doing renal pharm. And then of course there's a bunch of other stuff that I kind of made connections to right here. But for our question, this was a very easy and straightforward question where you would just pick the hydrochlorothiazide and you would know that because you would have that studied down. Right, so if we go to page 662, or basically just anywhere in renal pharm, right, you get to see all the different renal medications and where they work, right? And the main thing is when you let's look at hydrochlorothiazide. So if we do even a quick look at each one of them, mannitol is mainly known for any question with adverse effect of pulmonary edema. They'll give you a patient who came in with some kind of hypertension issues, right? You gave them mannitol and then they have pulmonary edema. You have to catch that. It's also contraindicated in patients with heart failure. Cetazolamide, acid azolamide, right? It causes acidosis. It actually alkalinizes the urine, but it's going to cause acidosis in the patient, so you can get proximal renal tubular acidosis, and of course promotes calcium phosphate stone formation, right? Because it's insoluble at a high pH, right? Cetazolamide causes acidosis. The high pH is the high pH in the urine. If your urine has a high pH, alkalinized urine, you increase the chances of calcium phosphate stones. And those are basically the only thing you really get questions about that. Loop diuretics, right, work with this channel right here, and the main thing here is loops lose calcium. You have to remember that, this statement, loops lose calcium. So clinically you could use it in hypercalcemia to lose more calcium, but losing the calcium can also cause hypocalcemia, which has its own whole list of side effects, right? Hypocalcemia has many effects in a person. Other than that, you can see it doesn't really mention directly over here, but let me see. Inhibit co-transporter systems, sodium potassium dichloride, abolish hypertonicity associated with increased prostaglandin E release, inhibited by NSAIDs, loops lose calcium, clinical use. Oh, there you go. It does mention directly hypokalemia, right? And you have to remember that. So hypokalemia, and you can have hypocalcemia as well, right? So hypokalemia, hypomagnesemia, the magnesium thing is significant depending on how severely you've lost magnesium, but not really something that you get too many questions on. Our question is on the thiazide diuretics, right? This stuff right here. And this one causes hypergluc, which you definitely get questions on. Patients can present with symptoms of any of these things after recently having started thiazide diuretics. The hypo stuff are the hypokalemia and hyponatremia, sodium potassium, both. Right. This is also the drug that's preferred in African American patients for hypertension. Right, preferred over ACE inhibitors, and you get questions about that stuff too. Right, so you have to make sure you know that. I think, yeah, right here, captopril is a first-line antihypertensive, along with other ACE inhibitors, is beneficial in these populations because it reduces the pathophysiology of hypertension in most black patients, is not significantly influenced by the renin-angiotensin aldosterone system, which limits the effectiveness of ACE inhibitors. Right, so for black patients, African American patients in general, you want to go ahead and use your thiazide diuretics. Right, thiazide diuretics. So that's a very high-yield topic. Very high-yield topic. You want to make sure you know these medications, know how this works. This question definitely freaked out a lot of people because they saw this up here and they're like, what the heck is that? Wait, was this actually part of the question? I don't think so. No, alright. That would be crazy if they put that in the question. Without this image, so this image is here for my explanation. Let's take a look at the question first then. So this is 125. The gene that codes for a protein normally found in the endoplasmic reticulum is mutated. So another biochem endoplasmic reticulum type of cellular trafficking question, which would freak you out if you got the other cellular trafficking question freaking you out already. The protein produced by the mutated gene remains in the cytoplasm. Alright? Which of the following mutations is most likely to impair the transport of the protein into the endoplasmic reticulum? So you look at all your answer choices. Conversion of a proline residue to a hydroxyproline residue. That, right, proline to hydroxyproline, that was something that was part of collagen synthesis and stuff like that. So you could think of that and remember that and understand that that has nothing to do with this question. Knock that answer choice out. We'll skip B. C says disruption of a lysine-rich amino acid sequence near the middle of the protein. Usually destruction of anything in the middle of a protein doesn't really affect how it's going to be handled. It's the ends of a protein that really kind of determine how it's going to be handled. Other parts of the protein are going to affect how the protein folds and stuff like that. But still a pretty difficult answer choice to knock out. Loss of a glycosylation site and premature termination of the polypeptide chain near the C terminus. Now, that and then answer choice B, deletion of a hydrophobic amino acid sequence from the N terminus, are both answer choices that you would really be stuck between because you're like, those are both different ends. Which one do I really pick? Right? So this was a fucked up question that was really just there to intimidate you. There's no real reason for you to know this. It's not in first aid. It's not really something UWorld talks about. I don't even think UWorld still has a question on this topic. And this is something that you would know if you studied like immense amounts of biochem for whatever pathetic reason, to be honest, right? Because biochem is really aggravating. Beyond what's in first aid, any extra biochem more than that, especially for the biochem majors, that is a rough life to go through. So I put the notes here. The N terminus is where you have signal peptides which define the target of the protein. Right? So you think of the N terminal as the postal code, right, for your boxes that you ship out and stuff like that. Typically, proteins are in the cytoplasm after they are made, but since they have tags at the N terminus, they go to different targets, and in our case, they're supposed to go to the ER. Now, if the protein is retained in the cytoplasm, this means the mutation disabled the tag, no postal code. Hence, it's kept in the cytoplasm, right? You have no destination for it. The mRNA codons are read from 5 to 3, and they specify the order of amino acids in a protein from N to C. The N-terminal signal peptide is recognized by the signal recognition particle and results in targeting of the protein to the secretory pathway. While the N-terminus of a protein often contains targeting signals, the C-terminus can contain retention signals for protein sorting. The most common ER retention signal is the amino acid sequence K-del or H-del at the C-terminus. This keeps the protein in the endoplasmic reticulum and prevents it from entering the secretory pathway. When I saw this question, I had no idea what the answer was, and I got it wrong. Right, so I actually did end up just picking E, premature termination of the polypeptide chain. But I was able to come down to between B or E. I didn't know the main difference between the N-terminus and the C-terminus when it comes to cellular trafficking. And then after doing this question, when I looked up more information, I found this information about it. Right? So that's what I'm showing at the top too. You can see your N-terminus and the C-terminus. And if you've done enough biochem or organic chemistry recently, then some of this will make more sense to you. But for the most part, just remember, N-terminal is the one that tells you where things are, like it's the final destination. And the C-terminal is more for retention, just keeping it in one place. 126. A study was performed that evaluated the relationship between television exposure and the development of learning disability in children. Children were divided into two groups based on the presence or absence of learning disabilities. The investigators asked many questions about the children's exposure to television. By comparing the likelihood of television exposure in these two groups, the investigators estimated the relationship between learning disability and television exposure using which of the following measures, right? You look at all your answer choices. So you have to first identify what kind of study this is, and right after that, you'll know what measure you have to use, because a lot of studies are associated with very specific measures, right? So let me tell you what I mean. So we go to right here, right? So you can see cross-sectional study is just disease prevalence, right? So it's really not anything else for that one. But a case control study, you can remember this as case control study, like I wrote it right here, right? And this OR reminds you that case control studies require odds ratio, right? And what do you do in a case control study? You have a case and you have a control. You compare groups of people with disease to people without disease. Very straightforward. And then you check what happened. In a cohort, right, you can think of it like the book does it now, cohort, right, RT, relative risk. Or you can also remember what I wrote right here at the bottom. Think cohort with 2 R's to remember relative risk, right? This one down here goes in line with the other one. So think cohort for relative risk. You would use the relative risk calculation for a cohort study. What does a cohort study do? It compares a group with a given exposure or risk factor to another group without such an exposure, right? This one, cohort study, is not related to disease per se. You don't pick your study people, whoever's going to be in the study. You don't pick them based off of disease, but rather based off of exposure. So in cohort studies, you would pick smokers, for example, whereas in case control study, you would pick people who have COPD. Right? Very big difference between the two, and you should always remember this is very easy to remember, because you know in the case control you have the case, and the case is the person with COPD, which means in the cohort you do not have the case. You have people who are potentially going to become a case when they get COPD later on. All right. So now our case, or our question, is a very classic case control study. You have people that, a study was performed evaluating the relationship between television exposure and the development of learning disability. Children were divided into 2 groups based on the presence or absence of disease, learning disabilities, right? The groups were divided based off of disease. If the groups were divided based off of who watches TV and who doesn't, that would be exposure. That would be a cohort study, right? So this is the 2 different ways the same exact question can present. But here they told you that the groups are divided based off of presence or absence of a case. Some of them have the case, some of them do not. Now, at the end, you immediately understand, once you found out that this is a case control study, it's going to be odds ratio. You pick that and you move on. Yes, I did. And you can definitely feel free to email me anytime. Alright, so this is stuff that you definitely want to master. The cheat sheet is also ready. I forgot to mention that. The cheat sheet's good to go. I have a tiny spot that's got some empty space in it. I'm trying to figure out what else I could add to it. Can't think of anything right now. If I don't think of anything by tonight, I'm just gonna post it on the community page, and then so the YouTube channel has a whole community page to it. It'll be right there. And that cheat sheet is something you want to rewrite every day, right? Every day you should start your day by first writing that cheat sheet out, because it helps you memorize all the things that are already in it. And every single day you should master at least 5 topics, which means that there should be at least 5 topics every day you're able to explain without the book in front of you, right? And that's not asking for too much. It goes to show how effective your studying is going. And this is something you should be able to explain without a book just because you watched this video, right? The difference between case control versus a cohort study, and the fact that for case control you would calculate it with odds ratio, and a cohort study you would calculate with relative risk. Prevalence would be for the first one, right, which was right here, cross-sectional. It's prevalence. You check in a specific time, right, on the timeline, what is happening right now, how many people have the disease. That's it, prevalence. Not incidence, right? Incidence is how many new people got the disease, and that's not what you check. You check how many people have the disease. This was a very easy question on visual disturbances. This is something I was considering putting on the cheat sheet too, but then I realized I can't, because you kind of need the color coding aspect of things. But you should still, when you study neurology and you get to the eye, retrace this every day until you have a good understanding of how this works. This is not so hard to memorize. You should be able to draw this out by yourself from your head without an issue, right? With color coding. So you should have the colors in the correct way, knowing exactly how things travel, and then eventually understanding where injuries have to be to get certain visual disturbances. Our guy, a 75-year-old extremely elderly man, has the sudden onset of partial loss of vision. Sudden onset of partial loss of vision. The visual fields are shown. The most likely explanation for the visual field defect is a lesion in which of the following, right? And this is the visual field they show you, right? So he's got this quadrantinopia, right? One quadrant is missing. And you look at all your answer choices. For each one, you should know exactly what's going to happen, right? So, for example, you can definitely knock out D and E, because if you lose your optic nerve, you're going to have the whole thing black, right? So D and E go away immediately. The optic chiasm right here, that's the one that causes both of them to be half affected, right? So that's not going to be the answer. That's usually pituitary related. You can knock out C. The occipital lobe, right? Occipital lobe, so all the way back here. The occipital lobe, left and right, it causes a different issue, not the one we're seeing, not this quadrantinopia. This quadrantinopia is a result of answer choice F. So another thing I want to mention is you could knock out all the answer choices, right? Because our answer choice is F. You can knock out all the answer choices that say right. Anything that says right. So you can definitely, you know it's not going to be any answer choice that has the right on it, because our visual field loss is on the right side of the eye, which means it must be the left side of the brain. Okay, and you gotta make sure you understand that aspect of stuff. So this is F, and then upper quadrantinopia, it is the temporal lobe, while lower quadrantinopia is the parietal lobe. That's another big difference. For upper quadrantinopia, also known as pie in the sky, that's usually a temporal lobe. And for anything like this one, a lower quadrantinopia, that's going to be the parietal lobe. And the patient has a right lower quadrantinopia, hence it must be the left parietal lobe that is affected. Okay. So not so bad at all. If we look at 587, so let me see. Yeah. Okay, so we had number 5, this thing. Okay. So you can see in the book, the defect is on the left side of the eye. So it's the right side that's affected. Dorsal optic radiation, parietal lobe. You have to memorize that. Right? Be able to trace things very easily, just as shown in the book, as shown in any image that's relevant for the visual field defects. You should know this by heart. And of course, the parts that involve the arteries are also not so bad either. Right? So there's a lot of ways of memorizing it. Use whatever works for you, but definitely get it down. And then of course you can knock out, as I said, optic nerve would be full blindness, optic chiasm would be the pituitary related, and you'd really just be left between occipital lobe, parietal lobe, or temporal lobe, and you have to remember what each one causes. The occipital lobe, right, which is kind of all the way in the back of the head, is not really one of the things that you can pick here, right? An occipital lesion right here, you can see number 6, left hemianopia with macular sparing, right? This one. But again, very rare type of question. If you do get it, then sure. And you can see how all 3 things are here as a potential answer choice. So they didn't leave anything. They really, answer choices, they didn't leave anything from this page. They picked every single one. So be ready. Right? NBME really tests how prepared you are for your upcoming test. 128, a 64-year-old man is evaluated for cough, dyspnea, and chest pain. He's afebrile, so no fever. X-ray of the chest shows an abnormal density in the hilar region. So in the hilar region, where left, right? Or both maybe. Lung tissue biopsy shows round cells with little cytoplasm that are about twice the size of lymphocytes. These cells are arranged in infiltrating sheaths that have neither a glandular nor squamous organization. Which of the following abnormalities in serum is the most likely in this patient? And then you look at your answer choice and it has all these kind of, metabolic stuff, right? Potassium, lipid, magnesium, glycemia, or natremia. And you should then start thinking, okay, this guy most likely has some kind of lung cancer. Lung cancers are known for causing all kinds of things. And we haven't gotten into that in my newer respiratory videos, but not the hardest stuff. So lung cancers cause all kinds of things. It's the last topic in respiratory pathology. And there's only one small cell lung cancer, and the small cell one, right? That's the one that actually makes ACTH, SIADH, or can be related to Lambert-Eaton, or any of these other, right? This is stuff that UWorld has questions on. The paraneoplastic myelitis, or subacute cerebellar degeneration, encephalitis, right? Lung cancer can cause all kinds of stuff. The other one, your squamous cell carcinoma. With squamous cell, you think of your parathyroid, PTH-related peptide, right, with all the other things. Our patient has small cell carcinoma. What they described was an oat cell, a cell double the size of a lymphocyte. That's what they were describing here. Lung tissue biopsy shows round cells with little cytoplasm that are twice the size of lymphocytes. That would be the small cell that they're talking about, right? Kochiski cell, small dark blue cell. Well, Kochiski cell would be the different thing. That's not the one I think they described. But, well, you know, it is. It basically is, yeah. Either way, you know from the answer choices they must be talking about the SIADH stuff, not the PTH, not the PTH related. They didn't describe a, they didn't describe a squamous cell, right? That's not what they were describing. So they did have answer choices that would kind of fit PTH too. The PTH aspect could be the hypermagnesemia, but that still wouldn't fit the answer either. So no answer fits ACTH or Lambert-Eaton related issues. It was pretty straightforward. You know this patient's going to have SIADH, and you just pick the hyponatremia. That's part of SIADH. So not much else to really talk about here. Know your lung cancers, know what they're related to, because patients don't present to you telling you they have lung cancer. Patients present to you telling you they have one of the symptoms of other things their lung cancer is causing, other things that their lung cancer is forming, right? Very important to get this stuff right. Not a question worth messing up. 129. Scientists have identified the flawed gene that causes about 1 in 6 of colon cancers. When the gene is working correctly, the gene product acts in the repair process that discriminates between the template and the newly synthesized DNA strand, correcting mistakes in the newly synthesized strand after replication. In which of the following processes is this gene product most likely to be involved? Right. So what they talked about, right? The gene product acts in repair process. It discriminates between the template and the newly synthesized DNA strand. That means that this is a DNA repair mechanism where both strands have been made. It identifies the newly synthesized strand and then fixes the issue. What they're talking about here is also related to colon cancer, which is another giveaway for which DNA repair they're talking about. So let's go take a look at your DNA repair stuff. As to DNA repair, you can have nucleotide excision, which is related to UV exposure, right? And our question was not about UV exposure. Nucleotide excision repair occurs in the G1 phase, right? Base excision repair occurs everywhere throughout the cell cycle. This was different previously in UWorld, excuse me, or not UWorld, excuse me. Previously in first aid, they had mentioned that this occurs in the S phase or something, or G2, occurs in G2, but that's not the case anymore. Base excision repair occurs throughout the cell cycle. Base excision repair is related to spontaneous deamination, which is also not related to our question. Our question is related to colorectal cancer, right? Mismatch repair is where you take the newly synthesized strand, right? Recognize it. Mismatched nucleotides are removed from this new strand. You have to remember, if you don't identify the new strand, right, that you can end up messing up or correcting the original strand, right? Your original strand is your actual DNA. You have to identify the new strand where you made a mistake and then fix it. Otherwise, if you mistaken the new strand and you think the new strand is your original strand and there's an error on it, you're going to fix your other strand to match that error, right? Now you're going to have endless errors. How do you recognize a newly synthesized strand? That's another big topic I talked about when we got up to this point in our biochem videos. For your cells to recognize a newly synthesized strand, well, a newly synthesized strand is pretty naked. Your older strands, the original parts of your DNA strands, those strands have a lot of epigenetics, right? You're going to have glycosylation if the patient has diabetes, all kinds of methylation, acetylation for muting and activating, stuff like that. The newly synthesized strand won't have so much of that, right? This was mismatch repair. So they gave you 2 reasons to be able to identify mismatch repair. The fact that this was related to colon cancer, and then the second because they described the process. Identify the new strand first. That's a mismatch repair. Alright, so not so bad. 130. A 34-year-old woman comes to the physician because of a 6-week history fatigue, and shortness of breath. Physical exam shows mild cyanosis and clubbing. Cardiac exam shows fixed splitting of S2. A mid-systolic pulmonary ejection murmur is heard. Okay. Echo shows a congenital heart defect, and the patient undergoes surgical repair. Patient is at greatest risk for intraoperative injury to which of the following? You look at all your answer choices, right? AV bundle, coronary plexus, coronary sinus, Purkinje fibers, or the SA node. So injury is going to happen by mistake, of course, and that mistake is going to be based off of where the surgery has to be. So you have to identify what kind of surgery this patient even needs, right? Because the patient is undergoing surgical repair. What are we repairing in a patient who has fixed splitting of S2? Fixed splitting is iconic for ASDs. ASDs have fixed splitting, where you have high right heart volumes, right? The ASD causes a lot of left to right shunt because sending blood into the right atrium, right, from the left atrium into the right atrium. Let me get my pencil. So let's say you have an opening right here like that. Sending blood from here to here is easier than sending blood from the left atrium to the left ventricle, where there's going to be higher pressures. Okay, especially if the patient has some level of mitral stenosis, which can be possible if the patient had rheumatic disease at a younger age. The ASD causes a diastolic rumble due to increased flow through the tricuspid valve. And as in our question, you can also hear a mid-systolic pulmonary ejection murmur. The ASD has your AV bundle, also known more commonly as the bundle of His, right? So the fact that they put the AV bundle was kind of a confusing way to test you on this, right? But the atrioventricular bundle is the bundle of His, the His bundle. It's the bundle that connects the signal from your atria to the ventricles, letting your ventricles know that they're done being filled. The bundle of His are pretty slow because you have to allow time for the atria to fill your ventricles, right? These are all things you have to remember and know. And this question was also doable and pretty straightforward. Nothing insane. The only way you could have any surgery where you would damage your SA node or AV node, they didn't put the AV node, right? An AV node would actually be a potential correct answer choice too, because it's in that area right there. But they didn't put the AV node, they put the SA node, and you can't really damage the SA node in fixing an ASD, right, unless you're fixing it blindly. But you could damage the SA node in any time you're trying to fix something related to the superior vena cava, right? Something related to that, but that's pretty rare. This was a hard question, right? Because this was something they made up, and even people who did pathoma didn't really per se know exactly what was happening. So 131, very notorious question of NBME 21. Which of the following best explains why the use of anti-idiotypic antibody is inappropriate as a therapeutic reagent for the treatment of a patient with multiple myeloma? Right? Why can you not use anti-idiotypic antibodies, antibodies against the idiotypes, as a therapeutic reagent for multiple myeloma? So then you look at all your answer choices, and it only gets worse as you keep reading your answer choices, and you get more and more intimidated because it might not make sense to you at all. So the way to answer this question, and I didn't get this right, so let's look at, I'll tell you what I picked. So A said an insufficient quantity of the immunogen is available to generate the reagent, and I didn't think that made sense, so I didn't pick A. Myeloma cells are not susceptible to antibody-dependent cell-mediated cytotoxicity. Now, this answer choice seemed slightly logical to me, but then I was like, if it's not susceptible to antibody-dependent cell-mediated cytotoxicity, then, you know, it's how are you going to kill it? And then I was like, well, if you can't kill it, that's exactly why it's a cancer. And I kind of picked B. That was my answer choice. C says myeloma cells can be killed only in vivo by cytotoxic lymphocytes. Anytime you have something that says only or always or never, those are pretty extreme. I try to avoid them if I have no idea what's happening in the question. D says myeloma cells do not have membrane-bound surface immunoglobulin. And then E, myeloma cells do not have tumor-specific antigens on their surfaces. So tumor-specific antigens were irrelevant for our question. Our question isn't talking about antigen antibody, it's talking about idiotype antibody stuff, right? You're looking for things against our antibody itself. So E wasn't going to be correct. So ultimately speaking, only B or D could explain the mechanism where using anti-idiotypic antibodies would not make any sense. You can't use anti-idiotypic antibodies if your myeloma cells do not even have membrane-bound surface immunoglobulins, right? So let's look at what this is about. Plasma cells, like mature B cells, the ones found in multiple myeloma, secrete antibodies, but immature B cells have antibodies that have not switched classes yet, right? So immature ones are going to be or they're not going to be able to switch classes. So you're going to have IgM and IgD. So no IgG basically. Since plasma cells do not have an idiotype on their surface, anti-idiotypic antibodies will not work. And you can see that right here. Right? You have your B cell with the membrane Ig, and then you have plasma cells. They secrete it, but they don't have it. So since they don't have the antibody on the cell itself, there's no idiotype for you to target. This is how an anti-idiotype antibody works. It connects to the idiotype of the antibody, right? But our plasma cells in multiple myeloma don't have antibodies on it, so it won't work. Right? B would have made sense if this was a possibility, but that is not the correct pathogenesis of how that works. So here the answer was just D. Myeloma cells do not have membrane-bound surface immunoglobulins. Worthwhile fact to know. I put it in my annotated first aid too, because I felt like that was something we should know. Plasma cells express Ig heavy chain transcripts that stop after the CH domains, thereby encoding the same antibody, but in a secreted form. Right? They secrete it. 132. A 70-year-old woman has had recurrent pneumonia, fatigue, and weight loss for the past 3 months. Serum T4 and TSH are within the reference range. T3 is low. Serum TSH concentrations increase after the administration of thyrotropin releasing hormone, TRH. Which of the following is the most likely diagnosis? Look at all your answer choices. You see euthyroid 6 syndrome. You're like, what the fuck is that? Then you look at hypopituitarism. Now, could she have hypopituitarism? Not really, because everything is okay, right? Her TSH is normal. If her TSH is normal, her TRH must be normal too, for the most part. And they don't mention any other pituitary-related lacks, right? Everything else seems to be fine for our patient. She just has recurrent pneumonia, fatigue, and weight loss. The recurrent pneumonia might be due to something else. The fatigue is due to her thyroid not being normal. Hypothalamic abnormality. A hypothalamic abnormality and hypopituitarism look pretty similar, so that doesn't make sense. Definitely not primary hypothyroidism, because TSH is normal. Definitely not a thyroid neoplasm, because T4 is normal. She's not making too much of anything. So then you come back to A again, and you're like, whatever this is, it must be correct. Because she does have sickness, recurrent pneumonia, and she is pretty euthyroid. Everything was normal, right? Euthyroid means like true thyroid or correct thyroid or whatever. So euthyroid 6 syndrome, also known as non-thyroidal illness syndrome, refers to changes seen in patient thyroid function tests administered in the medical intensive care unit during episodes of critical illness. It's not a true syndrome, and there are significant alterations in the hypothalamic pituitary thyroid axis in about 75% of hospitalized patients, especially the elderly ones. Right? Causes of euthyroid 6 syndrome vary to include critical illness, pneumonia, like our patient, starvation, and everything else that's been listed out right here. According to this article, after I searched for what is euthyroid 6 syndrome. An answer choice that was not too difficult to pick for this question, so you would just pick it. 133. A 39-year-old woman with rheumatoid arthritis develops proteinuria following treatment with penicillamine. Examination of a specimen obtained on renal biopsy shows diffuse, fine granular deposits of IgG and C3 in the glomerular basement membrane. Which of the following is the most likely diagnosis? So they gave away the answer by telling you the rheumatoid arthritis, first of all, that was one thing, and then telling you the examination aspect, right? Renal biopsy is diagnostic, and they had granular deposits of IgG and C3 in the glomerular basement membrane. That is E, membranous glomerulonephritis. How do you get this correct? So let's take a look at your renal pathology, right? So in the new First Aid 2020, they have this breakdown of what's happening. Right, so for nephritic syndrome, you're thinking inside you have blood coming out in the urine. Nephrotic syndrome, you're thinking protein loss, and then mix is both being lost. Our patient, right, they tell you has proteinuria, so you're already thinking of nephrotic syndrome. And in nephrotic syndrome, these are all your different answer choices, right? Which of which did they have focal segmental? They didn't. Right, but they do have IgA nephropathy, right? Minimal change disease. So let's take a look at the nephrotic syndromes. Let's go to it. So nephrotic syndrome. Oh, that's the first one right here. Right, nephrotic syndrome, minimal change disease, most common cause of nephrotic syndrome in kids. Not going to be our patient. Focal segmental. Focal and segmental, I think of this as segregation, and focal being like racism in a sense, or not racism, more like not racism. By focal I meant like local or focal, like you think of people from specific areas. And that the focal segmental aspect, this naming helps me remember African Americans and Hispanics. It also helps me remember, because of African Americans, the associations, sickle cell disease and Hispanics with HIV, right? All of these associations are made more so stereotypically with African Americans and Hispanics, but it's not just stereotypically, it's also statistically. It's just how patients present. You have to make this connection, whatever the reason might be. You have to make this connection so that you can remember this for the test. However, our patient doesn't have this issue, right? Our patient is not, we don't know where she's from. She could be Hispanic, she could be African American, but our patient is not undergoing any of those issues that are listed here. HIV, sickle cell, heroin, whatever. However, FSG is very difficult to rule out, because it can also occur for no reason whatsoever. So you have to remember the G, glomerulosclerosis, and our question does not describe glomerulosclerosis. This is not sclerosis. Biopsy showed you granular deposition, not sclerosis. Nor did it show you the other thing you have to remember. FSG, the G also stands for, and you can do this, just make believe it's true. This isn't what it's really going to stand for, but it does stand for glomerulohyalinosis, because you actually note a lot of hyalinosis as well. They tell you that right here, right? So you have to remember the glomerulosclerosis and hyalinosis. They didn't mention that in our question, so you don't pick it. Immunofluorescence can have IgM, C3, and all that, but again, not exactly our patient. Membranous nephropathy, very common in white people with solid lung tumors. You just have to know that. This fact about white people with solid lung cancers is statistical knowledge from online. You can search for membranous nephropathy, and the NCBI talks about how it's more common in white people with solid lung cancers. But mainly speaking, your answer choice is going to be this one. People who have this, antibodies to phospholipase A2 receptor. Our patient, we have no idea if they have that. Definitely our patient does not have any of these infections or lupus or solid tumors, as we just talked about. And generally speaking, membranous nephropathy you want to think of as being an elite member, aka being white. Okay, so it does not fit our scenario for our patient. So what's happening? Membranous glomerulonephritis. Excuse me. What else did I write here? So membranous nephropathy can occur after taking NSAIDs, penicillamine. Oh wait, did they have that here? Penicillamine stuff? Let me just check that real quick. Oh, the drugs. Sorry, that part does fit, right? This is the one for our patient, the penicillamine. Excuse me. Right, so what was I supposed to knock out? Just this, FSG. This one definitely didn't fit. She's not an African American or Hispanic. She doesn't have HIV or sickle cell. The drug part is not for focal segmental, but always remember the glomerulosclerosis. So you can definitely say that you're not going to pick this answer choice. And did they have it here? Glomerulosclerosis, they didn't. You know it's not post-streptococcal, so you knock that out. Goodpasture syndrome is the one that's related to your the basal membrane stuff. Not our question either, right? Because there's not antibodies against the basal membrane. IgA nephropathy, again, they didn't mention anything for you to pick IgA nephropathy. Knock that out. Membranoproliferative glomerulonephritis, membranous glomerulonephritis, and minimal change disease. Again, minimal change disease you would also knock out because minimal change disease occurs in kids and would have no symptoms visible unless you look at it on electron microscopy. So now, between D and E, membranoproliferative and membranous, the membranous one is the nephrotic syndrome, right? The membranoproliferative one, that's a nephritic. And this proliferative stuff is also due to something very specific. Hepatitis, no. The C3 nephritic factor, this thing. Right? This is a very big answer choice in UWorld questions for membranoproliferative. And then, of course, if they give you a biopsy where they talk about a tram track appearance or any of that stuff, then you go with it. But there was really no reason for you to pick glomerulonephritis, the membranoproliferative one. Membranous nephropathy. So when you do your nephrotic syndromes, right, when you're memorizing or studying, I like to say studying, when you're studying your nephrotic syndromes, one thing you should definitely know is this factor right here, right, proteinuria and what that causes, right, so you have a decrease in plasma oncotic pressure because you lost protein. Then you obviously will have no problem understanding minimal change disease because it's in the name. Just like that, have no problem understanding FSG because it's also in the name, focal segmental, black people and Hispanics with glomerulosclerosis on biopsy. And the last one, membranous nephropathy, right, where this one can be due to anything that wasn't up here, right? None of those things. It's going to be antibodies to phospholipase A2 or to drugs. And then these other infection stuff here, you're going to have to really be given the biopsy, which for our question they did, right? In our question they did, and that's really all there was to it. The penicillamine was the real giveaway, though. If you remember the penicillamine aspect, the drugs aspect, you would know that it's NSAIDs, penicillamine, gold, which can be in many drugs. It's all related to membranous nephropathy. Okay, so did they even mention why the penicillamine? Oh, okay, for rheumatoid. Yeah. So not a bad question, but of course it's based off of memory. If you don't remember, then you're not going to be able to get it right. Okay, we can definitely always cancel out answer choices. You can definitely, without any hesitation, cancel out A and F. If you remember Goodpasture and IgA nephropathy, you can cancel those out. You're left 50-50 between D and E. 134. A 78-year-old woman is brought to the emergency department by her husband 1 hour after the sudden onset of severe pain in her left leg. She does not recall any trauma to the area. Physical exam shows the left lower extremity to be cool and pale with absence of pulses. Right? No pulse in the left lower extremity, so left leg. ECG shows an irregular rhythm, so arrhythmia. Which of the following treatments is most appropriate to provide effective relief from these symptoms? Sudden onset of severe pain in her leg. Right, what are you going to do? So you look at all your answer choices. What treatment is going to provide effective relief of these symptoms? So first things first, you have to understand what's causing her left leg pain, sudden onset left leg pain. This patient, the way that she's presenting, very clearly has a DVT due to atrial fibrillation. The ECG, right? When you get any patient, you do an ECG, you see an irregular rhythm, you think atrial fibrillation. It's the most common thing for the most part. And your atria, remember, has this little pocket we talked about when we did my cardiovascular videos. I think it's right here. Yeah, right there. Right, so your atria has this little pocket in it. Not all of us have it, but many people do. It's a very common thing. This little pocket is called the left atrial appendage. UWorld teaches it in a question, right? It can also occur because of aging. In that pocket, you can accumulate blood. If you get an atrial fibrillation, that would cause a blood clot to come out, go into the left ventricle, go into the aorta, go down to the descending aorta or ascending aorta, and up into the brain, and either cause a straight or a deep vein thrombosis, right? Either way, whichever one it is, it's going to cause it, and that's what's going to happen in this patient. Everything was given for you to get that scenario down, right? Once you understand she has a DVT, you look at all your answer choices, the only way you can fix her is by doing the embolectomy. She has an embolus, you have to remove it. The other answer choices are all there to prevent emboli. They're all preventative. Everyone elderly should be taking aspirin every day, right? Bosentan is actually a medication for pulmonary hypertension, right? This N10 is, I wrote it right here, N10, right? So endothelin antagonist, N10, for pulmonary hypertension. Doesn't make sense to give her that at all. Clopidogrel is an ADP receptor inhibitor that prevents GP2B3A on platelets to decrease the risk of thrombotic strokes. She already has her embolus. Not going to help her. Fasciotomy is a limb-saving procedure used to treat acute compartment syndrome. Not going to help her. Right? The only thing was an embolectomy. Very interesting list of answer choices, but a pretty easy question. No real reason to get it wrong. Once you understand what's wrong with her and why it happened, you can pick it and you just know that's the only answer choice. There's no other treatment for DVTs. You have to fix the actual thrombosis. Get rid of it. 135. A 19-year-old woman comes to the office because of a 1-month history of 1-month history of abdominal pain and severe diarrhea. She's had 12-pound weight loss during this period, so she's really young and has severe diarrhea and lost weight. She's 5'6", weighs only 126 pounds, BMI is 20, physical exam is fine. Colonoscopy shows a cobblestone appearance of the colonic mucosa. That cobblestone thing should start ringing a bell for stuff. In addition, a stricture is found in a retroperitoneal portion of the bowel. So retroperitoneal is all the sad pucker stuff. A stricture. Okay, which of the following is the most likely location of this stricture? So they put the cecum, descending, sigmoid, and transverse, only 4 answer choices. And since they're talking about a retroperitoneal portion, right, very easy question because it had to be either the ascending or descending colon, and the only answer choice they gave you between the two is descending colon, so you pick it. That's all you could do here. They didn't even ask you what's wrong with her or anything else like that. Or what's in that stricture. They don't want any of that. It was just a direct question about whether or not you remember what are your sad pucker things. Right here. Right? Your entire sad pucker stuff. Suprarenal, which is your adrenal glands. Aorta and IVC, both of them. The second and fourth parts of the duodenum, because the first part is not. The pancreas, except the tail. The ureters, your colon, only the descending and ascending. Both kidneys, of course. The thoracic portion of your esophagus, not the portion up here. There's no peritoneum for it to be behind. And only some part of your rectum, but not your anus. Right? Very, very easy question for us right there because they only had one of those things as an answer choice, the descending one. Intraperitoneal structures are also worth understanding, which is basically everything that wasn't mentioned in sad pucker, right? And infraperitoneal, things below the peritoneum, is really just your bladder, the male reproductive organs. Only men infraperitoneal for the most part. And you can get questions about bleeding, right? That's another thing you often get questions about. Where did the bleeding occur? Was it retroperitoneal bleeding, intraperitoneal bleeding, and based off of that, you have to figure out whether or not you can stop the bleeding. Okay, retroperitoneal bleeding is very difficult to stop. Okay? You can't do anything back there. So UWorld had a question in this one right here, which many people obviously fucked up. Only 27% got it right. Where would the bleeding be? It would be in the retroperitoneal space. There was internal bleeding because of a femoral puncture site, and the femoral puncture site is kind of related to the aorta, so retroperitoneal bleeding, not pelvic cavity. No. Microbiology. So 136, a 10-year-old girl develops fever, malaise, loss of appetite, followed by excess salivation 6 weeks after exploring a cave with her friends. The salivation part immediately makes you think of rabies. Over the next week, she develops delirium, seizures, paralysis, and hyperexcitability. So you're further thinking, okay, rabies for sure. The most likely cause of her condition is a virus that has reached the brain by what route? Has to be the retrograde transport. That's like the only thing you study about, the only unique and very special cool thing you study about rabies, right? There's rabies, or not the only cool thing about rabies, but the only one of the many things that makes rabies cool. Rabies is cool and different from many of the other viruses because it's the only guy that really does something interesting like that. This whole retrograde transport through nerves making its way to the brain and then fucking shit up. The salivation, again, is also a very unique thing that makes rabies virus very cool. This is the sketchy micro image for it with the whole story, so that's its own thing. I mean, you can find these things online anywhere, so that's not a big issue. Feel free to pause the video and read it if you're trying to understand what the sketchy micro image is about. And then, of course, know all the other things you need to know. Bullet-shaped negative ssRNA virus, cytoplasmic negative bodies in the Purkinje cells of the cerebellum and the hippocampal neurons. The girl got it from some kind of bat in the cave. Okay, and that's it. 137, 27-year-old man comes to a physician for an examination before starting employment at a plastics factory. He has no history of major medical illness. He has never been sexually active, minimal contact with his parents and siblings, and has no hobbies. Right, but he came in. When asked if he feels depressed, he says no. He shrugs in response to congratulations about his new job. Physical exam shows a flat affect. This patient most likely has which of the following types of personality disorders. So the flat affect is something that's very schizophrenic, right? That's a negative symptom. Remember that negative symptoms mean that something is missing, and positive symptoms mean that something has been gained. And schizophrenia is notorious for the positive symptoms. People have gained some kind of psychotic activity. And then, of course, you also have negative symptoms. So this personality disorder, where you have a flat affect, is related to schizophrenia. It's called schizoid. The oid part helps you remember androids, robots. He's just like a robot. He's like a robot. He doesn't care for connections with others. He has no emotional expression. He's content being isolated and really doesn't have much emotion. Okay. So, again, nothing's wrong with him. It's just his personality. That's how he is. And if you don't like it, then you don't like it. 138, a 6-year-old girl is brought to the physician by her mother because of a 4-day history of round, shiny bumps in areas where she has eczema. Her mother remembers seeing similar bumps on a playmate when they attended a pool party 3 weeks ago. The patient has no other symptoms. Physical exam shows firm, smooth, umbilicated papules, 2 to 4 millimeters in diameter, in clusters. That is an infection. You have to understand what that looks like. The causal organism most likely belongs to which of the following viral groups? Well, they told you that she most likely got it from another person. That really helped, right? The playmate already had it, so another kid had it, and that kid gave it to her. Usually, questions about the pox virus involve people who came from another country, immigrants, who might have not gotten vaccination or whatever. So you look at all your answer choices, it couldn't be anything else but pox virus. Seeing that actually really helps. And what did they mean by umbilicated? So let's go to microbiology, viruses. Yeah. Okay, so pox virus, umbilicated, like that. Umbilicated means there's a little ulceration of a sort in the center. Okay, pox virus, very, very special virus, very important virus to remember. Unique in that replication occurs completely in the cytosol via virally encoded enzymes. Pox virus makes its own envelope using a DNA-dependent RNA polymerase. Note inclusion bodies at sites of viral replication. Okay, central umbilication. Very much pox virus. Gotta know it. It's the largest DNA virus and it replicates itself in the cytosol. Very different from the others. None of these other guys have umbilicated lesions like they described here. Papules. Paramyxovirus, herpes virus, flavivirus, adenovirus, they don't do it. Alright. 139, question about this stuff. I had seen this stuff a long time ago, back in anatomy. Our professor actually made us memorize that in med school. So when I saw this question, I wasn't completely lost. 35-year-old woman undergoes flexible nasopharyngoscopy because of chronic episodes of bacterial sinusitis. Purulent discharge from the right sphenoethmoidal recess is noted during the procedure. Which of the following best describes the location of this structure? So now, sphenoethmoidal, you know the ethmoid bones, right, kind of, are up here. You definitely want to remember that because the ethmoidal stuff is relevant to many other things, especially the nerves that come here and the sensation of smell and all that stuff. So there's a lot of ethmoidal stuff. So you should understand the sphenoethmoidal is probably also way up here. It's not going to be something that's all the way at the bottom. So anterior to the nasolacrimal duct, right, nasolacrimal duct from here, anterior to that, right, so anterior to the nasolacrimal duct. I mean, that's actually a pretty interesting answer choice. I don't know if I would cancel that out. Distal to the vestibule. If you don't remember where the vestibule is, you don't know what they're talking about, you can't cancel this out. But the nasal vestibule is right there. It's just the entry point. So, distal to the vestibule, well, I mean, yeah, sure, this is very far from the vestibule, but that's not the best way to describe this, so B would be wrong. Inferior to the hiatus semilunaris. Now, I didn't remember what the hiatus semilunaris might be, but inferior to it made me think it can't be that because I'm thinking of something really, really high, right? The sphenoethmoidal recess or anything ethmoidal should be all the way up here. Posterior to the middle concha, no. I remembered what the concha were, I remember what the turbinates were, so no, not posterior. Proximal to the fusion of the hard and soft palates, definitely not. And superior to the superior concha sounded perfect, right? That's a lot of superior shit happening here. And that was the answer, F. It's all the way up here. Right? Superior to the superior concha. I know where the sphenoethmoid area is, and it's above the nose, or at the very top of the nose. So I canceled everything down to F. Some people felt D was also right, but F is more correct. Posterior to the middle concha, I mean, sure, but F is more accurate. Definitely a bullshit question, no arguing that. And then this video gives you a little nasal cavity anatomy in case you need it. So I'll put that in the chat too. A couple minutes you could spend on nasal anatomy if you want, nothing major. Last question for this video, herpes virus, right? So 140, a 30-year-old man comes to the physician because of a pruritic rash on his lower back for the past week. He underwent liver transplant 1 year ago and has been maintained on immunosuppressive drugs since then. Physical exam shows vesicles containing clear fluid associated with ulcerated and crusted lesions. Which of the following is the most likely diagnosis? First of all, a 30-year-old man shouldn't really have any kind of pruritic rash, right? But then they told you why he has it. It's because he's immunosuppressed. Secondary syphilis is an answer choice that's ridiculously impossible here. There would be no reason for you to pick this. Syphilis is not about a pruritic rash, right? Erythema multiforme, dermatitis herpetiformis. What was dermatitis herpetiformis related to? Celiac disease. Not our scenario. Bullous pemphigoid, and then the more severe condition, pemphigus vulgaris. Those are related to antibodies that are going to cause this disease, even in someone who's immunocompetent. So again, not our case. When we see varicella zoster as an answer choice, you think, okay, he probably already had varicella zoster virus. It's a DNA virus that stays latent in your body, and it can reactivate when you're immunosuppressed. And he's been immunosuppressed for a long ass time, so it was a very straightforward answer choice to pick. Not so bad. Not so bad at all. Your DNA viruses become part of your DNA. That's kind of something you can understand, especially when it comes to the herpes viruses, or mainly when it comes to the herpes viruses, right? HSV1, HSV2, you can see latent in trigeminal. 1 is in trigeminal, 2 is in the sacral. HSV3, or HHV3, excuse me, which is your varicella zoster, is in V and Creander V1. as well as dorsal root and trigeminal ganglia, right? So it's problematic. It's very problematic. Reactivation of varicose zoster is a very common thing, especially in the elderly. And then you get your herpetic neuralgia, post-herpetic neuralgia, shingles, all kinds of other issues. Very problematic. Very, very, very problematic. All right. So that's it for that. In the next video, we'll continue on from 141 to another 20 questions. Thank you very much for joining. Keep studying. This weekend, we'll go into respiratory and knock that out.